Good morning, everybody. So we'll be starting on the next instruction course. So this is going to be your one-stop guide to do when, where, and how to perform retinal lasers. So because we are a little short on time, we'll be starting immediately. So the first speaker will be Dr. Prithvi. He'll be talking about the basics of retinal laser, their delivery systems, the lens selection, and the parameters.
Good morning, everybody. So I'll be talking about basics of retinal lasers. Basically, what is laser? Light amplification stimulated emission radiation. This is basically laser coined by Gordon Gold. So what is happening here is there is a electron which gets stimulated, and when it emits the energy, there is a light particle which occurs, and this light particle, when it goes through a totally reflected a box like thing which has mirrors which gets reflected and then comes out through one place, that is laser. So what are the properties of laser? It is monochromatic, it is coherent, collimation, polarized, and high intensity. So what are the classification of lasers that we have? We have solid state lasers, we have gas state, we have metal vapors, we have excimer, and we have diode laser. These are all the component of each of the lasers that are present right now. And over here you can see the various frequency and wavelength of particular laser, starting from 1064, that is ND-YAG infrared, 810 diode, 694 ruby, and we have frequency doubled 532 ND-YAG also. So all these lasers are different wavelengths which are used in our retinal lasers. So what are the modes of laser operation? One is the continuous wave, which delivers continuous stream of photons. The other one is a pulse laser, whereas energy pulses produced of few tens of microseconds to milliseconds. Q switch, that is energy delivered via pulses of very short duration. A mode, fundamental system, and multimode are very rarely used. What are the laser tissue interactions? That is photodisruption, photocoagulation, photoablation, photochemical reaction, and photovaporization. These are the few laser tissue interaction which occurs. Photodisruption is Q switch ND-YAG. Photocoagulation occurs in argon, krypton, and frequency doubled. Photoablation in excimer laser, and photochemical argon fluid, and photovaporization with the carbon dioxide. So what is the mechanism of action? That is photodisruption. Laser light has an optical breakdown. Miniature lightning bolt occurs, and a vapor which causes acoustic shock waves and tissue damage. Photocoagulation, target tissue is there, which heat is generated and the protein denatures. Photoablation is a high in energy which required to break the chemical bonds that holds the tissue together, essentially vaporizing the tissue. In photochemical, there is a photosensitizer like a hematoporphyrin, which gets sensitized with the photon or a photosensitization, which gives high energy, triple stage, energy transferred, and the molecular like oxygen or free radical causes the cell damage or vascular damage or the immunologic damage. Photovaporization, again, it causes carbon dioxide, which absorbed by the water of cells, and vaporization occurs, heat becomes cauterized, and cell disintegration makes it incision. And then the ionizing effect, that is Q6 NDR, causes ionization and plasma formation, absorption of the photons by the plasma, creating shock waves and tissue disruption. So what are the laser safety? That is class 1, 2, 3, and 4. No biological damage in the one. In the second, it is safe and momentary viewing, and chronic exposure can cause damage. Third is not so safe even in momentary view, and more hazardous in the fourth. Laser delivery system, we have slit lamp delivery system, which is connected. The console is connected directly to the slit lamp, and you can use the slit lamp to focus the laser. Then we have indirect ophthalmoscopy. The console is directly connected to the indirect ophthalmoscopy, and we can use with the condensing lens. Then we have transcleral and endophotocoagulation. These are the various type of lenses that we have. Over here, special mention to Vogue area centralis that we can use for focal laser. And then we have a Mainster 160 or a Supracode 160, which you can use for the PRPs. Different lasers. There also Goldman 3 mirror can also be used if you have that. But Mainster PRP 165 you can use till the periphery. Then focal lens, again, works area centralis and mainstream standard can be used for focal laser for the macula. So laser in retina can be used in multiple areas, that is for PDRs, retinal vascular diseases, clinical CSME focal lasers, choroidal neovascularization, CSR, PCVs, retinal breaks, symptomatic peripheral retinal lesions, retinochoroidal tumors. So what are the different types of grades? Grade 1, light bare blanching of RP. Grade 2 is mild hazy or faint white. Grade 3 is moderate or opaque dirty white. Grade 4 is heavy dense chalky white laser spots. So we'll go to the next thing. Prerequisites, consents, adequate dilation, topical anesthesia should be put, pain medication to be taken. Patient should be comfortable, clean the contact lens very clearly, put lubricants like viscoelastic or contact lenses because we have to keep it in the eye, and contact lens placement. So the assistant should wear a glass which can be protects his or her eyes from the lasers. So in laser photocoagulation, we can see the melanin absorbs the light and melanin absorbs light spectrum. Xanthophylls absorb blue light, and hemoglobin absorb the red is unabsorbed. Basically, yellow is absorbed. Laser in photocoagulation, continuous wave, that is green laser, frequency double, safer in macular diseases and krypton rated in macular conditions. I'll go directly to the PRP. Over here, you use a spot size of 200 microns, power 100 to 400 to get a grade 2, grade 3 burns. Duration 10 to 50 microseconds, and spot numbers are 1,000 per sitting for 3 sittings. So this is a case where PDR, you can see a very bad NVD, which you have to give good lasers. You can see over here the spot size and the interval should be good enough, and you can see complete regression of these NVDs. You can see over here the NVD is reduced very significantly, and this is not the end. You need to keep reviewing these patients. This is a RVO laser that was done. So you need to actually complete the whole area. Otherwise, you'll again see NVEs and NVDs coming. You can also combine your PRP with the FFA guide if you, to see the CNPs. Complications like vasovagal attack and decreased night vision, reduced contrast, all these can occur. Focal grid photocoagulation, you can see the spot size should be reduced to 50. Power also should reduce to 50. The duration should be less, and you need to grade 1 type of burn. Over here, you can see a focal laser that has been applied, and around 4 months, you can get the whole hard exudate also goes. Grid laser can be used for macular edema, and these are the complications. Barrage laser, again, retinal hole, you can barrage it completely so that it doesn't recur. There are subthreshold micropulse lasers. Just mentioning PDT with verteprofen, where you can use subfoveal classic CNVs, OHS, angiostreaks, CSR, PCVs, PDT parameters, and TTT, just to mention because there is no time. Thank you.
Thank you, Dr. Prithvi.
Yeah.
So there's be a little change in the schedule. So next we have Dr. Natasha speaking about among smart green laser systems, smart management for all retinal laser conditions.
Good morning, everyone. So I'm here with a financial interest. So let me declare that in the beginning. This is a talk from Appasamy, but it is also about my experience with using their equipment. So that is what I'm going to tell you. So what is the laser? It is a 532 nanometer solid state diode green laser that is used to treat various retinal disorders. And it comes with a laser console that emits the green laser treatment beam through 3 systems: the integrated slit lamp, the laser indirect ophthalmoscope for mid and far periphery, and the endoprobes for surgery. And the Amog Smart uses a conventional single spot for all the 3 delivery systems. And the Jericho uses a single spot and predetermined multi-spot patterns for slit lamp delivery and a conventional single spot for LIO and endo deliveries. Now, what is the advantages of this laser? It's a diode pumped frequency double true continuous wave laser, and thermoelectric cooling and air cooling is there. Coaxial slit lamp illumination beam, aiming beam and treatment beam for user comfort. The key features are the permanently inbuilt true color safety filter, so there is a hassle-free retinal view. There is an ergonomic compact design, so there is user comfort. It's lightweight and portable, so you can easily carry the laser either to various practice areas or you can carry it to your OT and to the NICU. And the Jericho has the versatile patterns that allow you to maneuver the laser through so that you cover the area completely. And because of this, the same console being used for both the systems, it gives you a lot of wide variety of use. It is a design that is ideal for surgeons and it is lightweight and portable. Touch screen interface is there, very user friendly and gives excellent visualization. There is quick access through the touch screen system and there is a wide magnification eyepiece and excellent treatment visualization. And the LED illumination in LIO gives you very good peripheral visualization. There is a stereoscopic lightweight optical system LIO that is very good to use, and there is also a save and recall option for all your settings. The highlights of the Jericho, like I said earlier, is versatile patterns are there and the LED illumination comes in the LIO. Now, patient comfort is prioritized in this system because of the less retinal edema, there will be less pain and less dazzle and faster vision recovery. And the best part is the ergonomic seating. You can very easily adjust it even for a wheelchair. For the surgeon, it is easy access to use and you do have the treatment lens already fed in, so you can select the lens and it immediately calculates your spot size. Shorter laser sessions, effective wider touchscreen display, and the fiber optic cable is metal shielded, so it doesn't keep breaking. There is an integrated voice confirmation, so you don't have to keep looking. You can actually hear the machine tell you. Parameter preset can be done, and the electronic micro manipulator allows the user to move the slit illumination beam and the treatment laser beam together so that there is less collateral damage. Like we already covered all the impactful benefits for the patient, and the most important being the comfortable position. Now, another thing that Appasamy gives you is an unmatched market presence and after-sales service. So they have a high-volume installation across India, affordable price, faster customer service. There is no visiting charge for equipment service. There is no service charge for the service units. There's AMC and CMC facility, extended warranty facility, and an unwritten 3-year warranty as well. And there are a lot of add-ons that can be taken, like an Insight View display inside your eyepiece, 3D mouse for easy selection of parameters, a wireless foot switch. All this can be added at an extra cost. Now we know the competitors in the market. The main competitor is the Zeiss that we all, most of us have used, and some of the Iridex and Nidec and a lot of other players in the market as well. And these are comparison tables of all these major players, but you can see that almost all the facilities that are being given in the other players are all there in the Appasamy, Amog Smart and Jericho lasers. So these are just comparison tables with all the other competitors. Now, just one part about why I would recommend that you buy, if you're planning to set up a clinic, a retina services unit, why I would recommend you to go for the Appasamy unit is one, is that anything when you are setting up in a retina affair, it is very, very expensive. All the equipments are expensive. And if you look at the cost effectiveness of the Appasamy laser, it is about 3 times less than their competitor. So that gives you really good value for money. And I have been using it for the last 20 years now, and the after-sale service is very, very commendable. just you pick up the phone and they are immediately, they will tell you at least when they are reaching, and the service is done very, very fast. And the portability is very good because I do ROP lasers and we can't have a dedicated ROP laser machine in the NICU. So it has to be taken from the OP to the NICU. And because this is it sits on small trolley table, you can easily shift it up. You can even shift it by hand. But of course, most hospitals have their biomedical coming and shifting in. But it is very, very easy to shift. And so it's very versatile and gives you value for multitasking as well. And the ease of use and ergonomics. So you have seen when you use the indirect itself that the higher end indirects, if you go for a Keeler or the Hain indirect, it sits easily on your head and it doesn't strain your neck so much. But the LIO, when it came to the LIO, they have really done it so well that it is as good as the Zeiss indirect, and it is compatible with the Zeiss laser as well. So if you want to use it for the machine, you can still use theirs with a small adaptation. So a lot of things why you should go for an Apasami in there, the laser system, if you're starting up a retina service in your hospital. So that's all from me. Thank you. Thank you, Rohan, for giving me the space.
Thank you, ma'am. If anybody else has any questions or anything for ma'am? Thank you, ma'am.
I have another session, so I need to go.
Next will be Dr. Shishir. Will be talking about the vascular occlusions, its indications and technique. And also he'll be taking the peripheral lesions, the treatment indications and techniques.
Shishir. First. Yeah, good morning, everybody. So I'll be having, thank you, Dr. Rohan, for having me here. So I'll be giving two talks. So one is on vascular occlusion and another for retinal peripheral lesions. So let's talk about laser for vascular occlusions. So not much is written about in textbooks about how to laser these, vein occlusions. So no financial interest. So we know when a patient comes with vein occlusion, you cannot reverse the vein occlusion. The vein occlusion won't go. But what the treatment for vein occlusion is for the complications of the vein occlusion, which are macular edema or ischemia, or when the patient presents with RD or vitreous hemorrhage. So when there is macular edema, you can treat with anti-VEGF or a macular laser. When there is ischemia developing NVI, NVD, you do laser. And when there is vitreous hemorrhage or retinal detachment, you do a vitrectomy. So let's look at some cases. So this is case 1, 65-year-old female, hypertension, dyslipidemia, 6/6 vision, superior hemivein occlusion. So no macular edema here, vision is 6/6. So she came to know after coming to us that she is also hypertensive. So got all that evaluated. Now this is follow-up without treatment, follow-up after a month. So this is month 2, vision is still 6/6. This is month 4, all the hemorrhages are slowly resolving, no anti-VEGF, no laser, vision is still 6/6. This is month 6, and now there is something happening. Vision is still 6/6, but on close look, you can see this small reddish patch just above the disc there. And when you look, just zoom into the photograph, you can see this new vessel which is happening above the disc. So this is like 1 DD close to the disc. So I'll say that this is like an NVD. And that's when I do the superior sectoral laser, which I cover 180 degrees of the fundus. And this is 1 month post laser, vision is still 6/6. And post 6 months post laser, vision is 6/6, and the laser is holding pretty well. So here the indication is only when you develop the NVD, then only you need to go in and do your laser. Otherwise, the patient can be observed if the vision is good. So let's look at another case, case 2, 58-year-old female, hypertensive, 6/6 vision here again, but she came with complaints of floaters. And she was found to have an inferior BRVO with vitreous hemorrhage, no macular edema. So this is the NV which is developed over there, and you can also see this is quite old because there are collateral vasculature also which is developed over, and along with that there is NVE also, and which has caused the bleed and the hemorrhage which has come. So now the initial treatment in this patient will be to laser, and then you need to closely follow up. So this is close follow up after the laser, and however 6 months after the laser, there was a vision drop to 618. And now when the patient has vitreous hemorrhage, now here the patient was advised vitrectomy. But the first treatment will always be a laser. So let's look at third case. Now this case is just to show you how much to laser, what extent will you laser in these vein occlusions. So the posterior extent to where the ischemia is there, the ischemic vessel is there, and then the laser should go on till the periphery up to the aura. So in these vein occlusions, the ischemia is up till the aura, so you should laser right from the posterior up till the ora serrata. So let's look at another case. Case 4, 71-year-old female. She was referred for doing a laser. Again, no complaints in the left eye. She came for right eye cataract surgery. 6/6 vision in the left eye. Again, you can see this ischemic, sclerosed vessels over there. But tried searching for NVD, NVE. There is none of that, and there was no NVI also. But however, she had this collateral vasculature. You can see the collateral vessels which are supplying the ischemic zone from the superior part, and it's supplying to the inferior part. So here again I did not do the laser because already it was perfused. So month 4 follow-up, 6/6 vision left eye, no NVI, no NVE, no NVD. So here again I did not do any laser. So these patients can just be closely observed and followed up. So learnings is close follow-up and pan-retinal or sectoral laser in the setting of ischemia only, or when there is NVA, NVI, NVD or NVE, and gonio needs to be done every 3 months along with undilated fundus examination, undilated anterior segment examination to look for NVI also. So now let's look at case 5, 58-year-old male, diabetic hypertension, a 660 vision right eye. So he had an NI CRVO, that is he's got a CRVO also. You can see the hemorrhages on top and below, and then on top of that he's got a ischemic hemi-CRVO. There is a hemi-CRVO. So he has had 2 occlusions. So one, there must be a small CRVO which has happened, and on top of that he's got a hemi-CRVO also which has happened in the inferior quadrant, and he has come with macular edema and those exudates what you see. And there was suspicion of an NVI, and IOP was only 15. So here we went ahead and decided to do anti-VEGF followed by 3 sittings of pan-retinal photocoagulation. So this is after anti-VEGF and 3 sittings of PRP. You can see the extent of the laser. It's almost up to the periphery there. That's how much the laser you have to do, up till almost till the aura. And after this treatment, the vision is 618, and we also did a macular laser because she's already taken multiple anti-VEGFs. So we also have gone and given a grid kind of laser close to the macula there. So let's look at another case. I think the final one, 6/6 vision, 80-year-old male, hypertensive, 636 vision in the right eye. You can see gross macular edema. So he's got a superior branch vein occlusion. And after treatment, this is a wide field photograph. You can see the extension till the periphery. And then after treatment with dexamethasone implant, that is steroid implant with and also a macular grid laser, you can see how posterior you have to do the laser over there. So it almost acts like a macular grid laser, and then he was stable post treatment with vision remaining at 636 because of the chronicity, there was some atrophy at the fovea. So some learnings from these cases. So if it's a BRVO, the outcomes are good with macular laser, and the BRVO study also says that macular laser was the standard of treatment before the advent of anti-VEGFs. So now you can combine treatment with anti-VEGF. After you treat with anti-VEGFs, once the macula is flat, then you can go and do your macular grid laser. But there is no visual benefit in CRVOs when you do a macular laser. So in CRVO, there is no role of macular laser as the edema doesn't resolve with the macular laser. But however, the recent studies shows that if you do it in a young patient, then it's of some benefit, but not significant. So the final case 7, 75-year-old male, neovascular glaucoma due to a CRVO. You can see the new vessels at the iris over there. Now in such a case, if the view is there, then you will go and do your 3 sittings of pan-retinal laser along with an anti-VEGF injection. So I won't go much in the details of NVG because it's a totally different topic. So to conclude, pan-retinal laser is the gold standard for complications of the vein occlusions. And when you can combine laser with anti-VEGF or steroid injection, especially when there is macular edema, follow-up is extremely important even after laser treatment. And macular laser is good in BRVOs, but not so effective in CRVOs. Thank you.
Thank you, Shashi, for those
I'll go for
wonderful
my
cases.
second talk.
Yeah.
So thank you once again. So this talk is on peripheral retinal degenerations to treat or not. So a lot of patients come to your OPD with these peripheral lattices or breaks. So now this talk will dwell on whether to treat these patients or not. So why to treat these peripheral lesions is we have annual incidence of RD 10 to 18 in 100,000 people, and 20 to 40% of them have had cataract surgery when they present with this retinal detachment, and half of that occurs in myopic eyes. So what is peripheral degeneration? It's a deterioration and loss of retinal tissue leading to thinning in the retinal periphery. And patients who undergo refractive surgery to reduce myopia should be informed that they remain at the risk of RD despite reduction of the refractive power. So those patients with peripheral degeneration who are undergoing LASIK and all should be informed that even after the LASIK, they remain at a risk for retinal detachment. So I won't go much into this. So there are classification based on the intraretinal, vitreoretinal and chororetinal degenerations. So most commonly when you present to the OPD is your lattice degeneration. Incidence is 6 to 8%, 30 to 40 in myopes, and 30% RD associated with these lattice degenerations. So let's look at this case. So this was a patient who came with a lattice degeneration to our OPD. So he was asked close follow-up and observation, but then he came after 2 years with a subtotal retinal detachment, what you see over here, and then the lattice has given way, and this is post-treatment after vitrectomy, the retina is attached. So see, now this other eye is at risk to develop a retinal detachment. So he had a lattice with hole in the other eye, and that has been nicely barraged over there. So you can see the type of laser which we have done, close knit laser, all the spots are coalesced together. So that kind of laser you need to do for these retinal degenerations. So that's a close-up view of the laser which we have done in the periphery. So you can either do with your contact lens or you can do with your laser indirect ophthalmoscopy. So snail track degenerations are also there. So prevalence is 10% and myopes are more frequently affected. So shape, size and orientation will be similar to a lattice, but it will appear, little more longer. So this is one example of a snail track degeneration with holes. So this patient asymptomatic, he came for a routine exam and we found this snail track with huge retinal holes in the periphery there. So this you cannot leave, you have to laser it, and this is post-treatment with the laser. You can see how close, it's not like a PRP laser, how close those burn marks are together, almost confluent with each other, and you have to laser and connect up till the ora serrata. So you need your indirect laser to do this kind of a laser barrage in the periphery. So next are some of them atrophic holes. So they are not associated with vitreoretinal traction, but they can be present with lattice. Now it is always questionable whether to observe these patients or whether to laser them, but atrophic holes can be observed and closely followed up. But if the patient cannot follow up, then you can might as well give them an option of lasering these holes. So next, snowflake degeneration also can present, no requirement for laser here, and white without pressure also as the peripheral retinal degeneration. Here again there is no requirement for laser, but however white without pressure can predispose to giant retinal tears, and such patients also needs to be closely followed up and observed. So what causes an RD in an eye with a peripheral retinal degeneration? It's mostly because of the PVD which occurs. So when the vitreous is detached from the retina, it tears one part of the retina away, leading to a horseshoe tear, and then that horseshoe tear causes that is an opening for fluid to go in and cause a retinal detachment. So there are two types. One is an acute symptomatic PVD, and sometimes they can be asymptomatic too. So when you have an acute symptomatic PVD, then you will have flashes and floaters when you have a symptomatic PVD, and that can cause, vitreous hemorrhage can be a presenting thing, even retinal tears as well as an RD can happen. So they need a repeat retinal exam after 4 to 6 weeks. Once you have when a patient presents to you with PVD, you need to keep calling them up frequently as the PVD may keep progressing. So slowly it will detach from the posterior, then go up till the periphery. So these are the horseshoe tears, which are flap tears. They have traction. So they are high. When you see them, you should always laser them, and they are high risk for developing retinal detachment. So let's look at this case. He came with a vitreous hemorrhage. He came with complaints of floaters. So he had a PVD with a mild vitreous hemorrhage, but when you look in the periphery, you see there is a horseshoe tear, which is the source of the blood. The blood has trickled from the periphery and come to the posterior part, and then the horseshoe tear has been lasered and connected all around up till the ora serrata there. And this is 4 months after follow-up. You can see the tear has been nicely lasered, but however some vitreous condensation is still there. So he's not complaining of floaters, but he's still on follow-up. So the degenerations which dispose to an RD is important. Lattice, snail track, retinoschisis, white without pressure, holes and tears, and which don't predispose to RD also you should know. Snowflake, paving stone, honeycomb, white with pressure, meridional folds. So there are some AAO treatment management options, but then it's all related to the Western population. So we need a uniform guideline. So in India, there is no uniform guidelines to treat these peripheral degenerations. So there are no clear recommendations. So there are different opinions, which creates doubts and confusion. Like, I would laser, I would not leave it. I would not laser. And due to the medical legal issues also, we tend to sometimes overtreat these patients. So suggested approach is step 1, what is the lesion? What are the vitreous changes surrounding the lesion? And you should also look at the risk factors. What are the risk factors in that patient which can predispose to a development of a retinal detachment? So here few of the recommendations are all symptomatic and asymptomatic horseshoe tears, operculated holes, lattice with retinal holes, atrophic holes should be treated promptly. So these are the Indian guidelines. All symptomatic lattice degeneration without retinal holes and atrophic holes, treatment is usually recommended. You can advise the treatment to the patient or you can tell them to closely follow up. And all asymptomatic lattice and all, they can be observed. And eyes with atrophic holes or lattice with where the fellow eye has already developed an RD or where there is a family history of a retinal detachment, they have to be treated. So they can be considered for treatment. So always family history, ask one-eyed status, a fellow eye having a retinal detachment, all this you need to consider before treating these peripheral degenerations. And patients undergoing refractive surgery, you need to look for thorough examination to look for these lesions. And prophylactic barrage laser to degeneration should be done 2 weeks, at least 2 weeks before planning the LASIK or a refractive surgery. And then retinal examination should be done at regular intervals for development or progression of the PVD, tears, and these macular other pathologies. So thank you.
Thank you, Shishir, for that wonderful presentation. If anybody has any questions for Dr. Shishir?
Please.
Hi, sir. Nice talk it was.
Thank you.
Sir, for pre-LASIK, if it is there is a lattice without a hole, also will you suggest a laser?
So again, there is a confusion over there. Usually what happens these LASIK patients is they don't tend to follow up after treatment. So in them, you need to advise that you have to undergo a barrage laser. That is one concern. The second concern is that some surgeons think there is a theoretical risk of retinal detachment when you put that suction ring over the LASIK and that causes an increase in the pressure. So that doesn't really cause a RD, but there is a theoretical risk that can happen. So that's the reason why you laser these lattices before the LASIK. But if it was me, my opinion, I would definitely laser. And 3 weeks after the barrage laser, they can do the undergo the LASIK procedure. Yeah. Any other thing? Okay. Thank you.
Thank you. So next we have Dr. Basil, who will be taking the managing macular edema with focal and grid laser treatments.
First of all, thank you, Rohan, for giving us the opportunity to present. So today I'll be talking about managing macular edema with focal and grid laser treatments. So as you know, so as you know, the laser tissue absorption by the retina is important because there are various pigments in the retina, including the melanin in the RPE, which absorbs from 400 to 700 microns. That is the blue, yellow, and the red wavelengths of light. And the xanthophyll, which is present in the inner and the outer plexiform layers of the macula, will absorb the blue light. And so we should always avoid blue light and use green or the yellow lasers. And also hemoglobin, which is present in the blood of the vascular retinal structures, absorb yellow, green, and blue wavelength. So green or yellow lasers are preferred for photocoagulation of vascular structures of the retina. So this was already mentioned, the laser parameters, which includes the duration, interval, spot size, power, etc. So the laser parameters, what we check is the wavelength, the power, duration, and the spot size. And for slit lamp delivery of the laser, contact lenses are required. And the most common is the Goldman 3-mirror lens, which is a plano concave lens, which gives a virtual erect image and less field of view. But the convex lenses give real and inverted image. And macular lenses, they give high magnification but less field of view. And also it has to be kept in mind the laser spot size we keep on the laser machine gets altered depending upon the contact lens we use. Wide field contact lens, it's magnified, and in macular lenses, it is minified. Now, the prerequisites include the patient consent, adequate pupil dilatation, topical anesthetic, patient comfort, clear contact lens, lubricating material. And the ideal spot size for focal laser would be 50 to 60 microns, and for grid laser would be 100. And the power, it again varies depending upon the media clarity. If there is cataract or PCO or vitreous hemorrhage, the power would be high. And the RP pigmentation, that is basically in Asians, the RP pigmentation is very high. So the less power of the laser is required. And also depends upon the machine optic fiber laser media clarity. Now, coming up on the grades of burns, there are grade 1, 2, 3, and 4, which was already told before. So this is the grade 1 laser, which is just a faint blanching, it can be seen. And the grade 2 burns, these are basically used in the grid macular photocoagulation. And coming on to the duration, the conventional laser, we use 150 millisecond, and single spot size is the time to complete the PRP. And the newer ones with the Pascals, it is about a 20 microsecond, up to 25 spots in one single shot can be given. And the advantage is that in conventional laser, there is a continuous delivery of the laser energy to the RPE, and it's transferred to the inner retina, which results in swelling and later scar formation, which involves the inner retina. And the Pascal or the pattern scan laser uses ultra short pulses, and which are about 10 to 20 milliseconds. Whereas the short pulse laser, it is confined to the RP and the outer retina. Therefore, it's uniform, and the small scars in the Pascal will also help in the choreo-capillary damage would be less. And coming on to the indication, the anti-VEGF has actually revolutionized the treatment outcome in diabetic macular edema. So as first line, focal therapy and grid laser is reserved primarily for non-center involving diabetic macular edema. So as you know, the grid laser, the another indication for the focal or the grid macular photocoagulation would be clinically significant macular edema. And with the OCT scans, the CSME definition has been slightly changed to new classification, which is the center involving and the non-center involving macular edema. And anti-VEGF therapy has revolutionized the treatment outcome of DME. So first line of focal and grid laser is primarily reserved for non-center involving diabetic macular edema. So how to do a focal laser? So the ideally 50 to 100 micron spot size is taken, and 50 to 100 millisecond duration, and the power should be just adequate to obtain darkening or whitening of the microaneurysms. And the direct photocoagulation of the leaking microaneurysms on fluorescein angiography, which are outside 500 microns of the foveal center, is done, and there is a direct treatment of the focal fluorescent leaks. And these, the focal laser, the ETDRS has shown that the laser treatment has reduced the incidence of moderate vision loss by 50%. And discrete points of retinal hyperfluorescence or focal leakage that are 500 microns or more from the center of the macula, and the focal leaks, and the laser is done to the focal leaks, which is 300 to 500 microns from the center of macula, or previously treated but CSME, which is still persisting, or visual acuity, which is 20 by 40 or worse. And these are the pictures showing that faint grade 1 to 2 burns, and this is used to blanch the microaneurysms and closing the leaking microaneurysms. And direct focal laser with green laser of 532 nanometer or yellow laser with 577 nanometer are ideal for direct focal lasers. Now this is another example, if you can see, following the grid laser, the hard exudate actually, which is here, it's actually reduced following the grid laser therapy. So these are the clinical examples wherein the focal laser have succinate focal maculopathy has been reduced the macular edema on these OCT scans, as you can see. Now coming on to the grid laser is reserved for diffuse macular edema between 500 microns to 3000 microns from the foveal center. And grade 2 burns, which are 2 burns apart, 100 micron spot size and 100 millisecond duration, and covering the area of the diffuse macular edema outside 500 microns. And for this, green and yellow lasers are preferred. And so this is how a grid laser looks, covering the entire area of the macular thickening outside 500 microns from the foveal center. So the mechanism of action is that the laser removes the unhealthy RPE cells which are replaced by the viable RPE cells, and it destroys the retinal photoreceptors and increases the oxygen consumption, which in turn decreases the blood flow within the leaking vessels. And it simulates the existing RPE cells to absorb more fluid and simulates the vascular endothelial proliferation and improve the integrity of the inner blood retinal barrier. And it is likely that a combination of all these will underlie the efficacy of the grid laser treatment. Now, the complications include the accidental foveal burn. That is, when we are doing a foveal laser, when suddenly if the patient shakes his head, it can result in a foveal burn. And paracentral visual field loss or scotoma, and the scar enlargement or encroachment to the foveal center, subretinal fibrosis, and drop in vision later on. Because of the heavy burns, there can be the scar enlargement, and that will go into the foveal area. And also iatrogenic choroidal neovascularization, also subfoveal migration of the hard excretes is another complication. Thank you.
Thank you, Dr. Baser. Does anybody have any questions? Thank you. Good morning, everybody. So next we'll be talking about mass strength panretinal photocoagulation for PDR. So why PRP? So initially you had two landmark studies, both the DRS and the ETDRS. DRS established that panretinal photocoagulation, it prevents severe visual loss, and ETDRS said that it should be reserved for high-risk cases, avoiding mild and moderate NPDR. PRP mainly works by increasing the retinal oxygenation. It increases the diffusion from the oxygen from the choroid and also eliminates the hypoxic areas and vasoproliferative factors. Now, what are your indications? When do you do PRP in diabetic retinopathy? So mainly you have four indications. Sorry. You have neovascularization at the disc, neovascularization elsewhere, any pre-retinal or vitreous hemorrhage, and in advanced PDR development of neovascular glaucoma. Now, traditionally PRP is basically given either through a slit lamp delivery system or even through an LIO. And the various power settings, it can vary. Power can vary from 200 to 600 milliwatts depending upon either the retinal pigmentation. If your pigmentation is a more heavy, it requires lesser power, whereas a lightly pigmented fundus will require more power to get the burn. Other factors include a media haze, the patient has cataract or vitreous hemorrhage. It requires more power to get your desired burn. The spot size will be fixed on an LIO, depends upon the contact lens use. Duration can vary from 0.5 to 0.2 milliseconds. Intensity, you ideally aim for a 2 or a grade 3 burn. Grade 1 being just visible, grade 2 being faint white, grade 3 being dirty white, and grade 4 being a chalky white burn. And distribution ideally should be at least one burn width apart. And number of sessions, you usually aim for a two or three sessions. And with a CKD patient, you ideally go for a 3 sessions per eye. Now, where do you laser? So basically, you have two fixed points in the eye. You have your optic disc and your fovea. So because diabetic retinopathy is a posterior disease, you ideally require very good posterior laser. So it should be 1 disc diameter nasal to the disc, 3 disc diameters temporal to the fovea, and at least 1 disc diameter above and below the vascular arcades. Now, how do you laser? So getting a good posterior laser is very important. So the technique especially when you are starting out, you ideally need a good demarcation before you start lasering to avoid excessive posterior laser. So first you take your slit, make it into 1 disc diameter, enlarge it to become so it becomes 2 disc diameters. And move the slit nasally so that now your spot size will be 1 disc diameter nasal to the disc. Apply your laser marks and get a border extending to the nasal area. Similarly, laser it inferiorly. Now switch off your laser beam so to avoid any accidental foveal burn. From the fovea, take your slit lamp, move it again so you can get a 3 disc diameter width. Apply your laser burns and get your temporal laser marks. This is again followed by your inferior laser boundaries. So now you have, when you're starting PRP, get your boundary done first so that you avoid any posterior laser. This is also followed by a fill-in PRP in that area to get that correct 180 degree. Now, what do you do when you have fibrovascular proliferations? So still PRP is essential because it reduces the VEGF drive. So it reduces the progression of the fibrovascular proliferation. It stabilizes the existing fibrovascular tissue, reduces the risk of VH, reduces chance of TRD progression. And also prior to surgery, it can induce PVD, which is helpful. It can reduce the intraoperative bleeding risk and lowers the risk of postoperative recurrent hemorrhage. When you have fibrovascular proliferation, ideally you should aim for a 3 to 4 disc diameters away from the FP, so to avoid any further traction on the well. Now, what happens when you have a vitreous hemorrhage? So the flowchart I usually like to follow is, if your view is good, then you do a full PRP. Now, if you have a partial view, you can do an accessible PRP to the visible areas, reassess the patient after 2 weeks. If the view improves, you can very well do your completion of the PRP. If still the view is bad or if it worsens, your options are either vitrectomy and endolaser. Now, what if the patient, there's no view? First, you do a B scan to rule out any TRD or a macular TRD or a combined retinal detachment indicates a need for a vitrectomy. If there is no fibrovascular proliferations or a TRD, you can give either an option for an observation or even an intravitreal injection to the patient. If it resolves, you can go for your PRP. Still, if it's not resolving, then vitrectomy and laser is your option. So there's another term which we say it's called an add PRP. So these are additional PRP or a supplemental PRP. We do these when you have neovascularization persisting, where there's missed skip areas, or if the PRP was incomplete, either due to patient-related factors, or if a cataract was there and now after the cataract surgery the view is better, or even there is progression of the PDR. We do add PRP mainly either to the mid or the far periphery or in areas of non-perfusion, or even between the PRP burns. So there's another new machine, relatively new, called Pascal. So this is a pattern scanning laser. So it's a semi-automated multi-spot burn patterns with 20 millisecond duration. It has less thermal damage, less burn speed, and it has better patient comfort and safety. But some studies have suggested they'll be more likely to have a recurrent neovascularization or require additional PRP for PDR. What are your signs of an effective PRP? You have your neovascularization regression. You have mature laser scars. These are well with no skip areas. There's hemorrhage gets controlled. There's no new hemorrhage or resolution of the vitreous hemorrhage. Your anterior segment stabilizes. Your NVI regresses, or even retinopathy stabilizes. The complications you usually face are either vasovagal attack, reduced contrast and color, can have peripheral visual field loss, decreased night vision, over-enthusiastic or excessive laser can result in choroidal detachment and exudative RD, pre-retinal membranes, and even accidental foveal burns. The other options which are newer include a subthreshold micropulse laser. These mainly act by stimulating the RP and preserving the retinal structure. But they may require multiple sessions, and it's a less predictable and slower risk of neovascularization. Overall, conventional PRP is still the gold standard for high-risk PDR. Thank you. If you have any questions, please can just please.
Nice talk, Mr. Sir.
Thank you.
Sir, I have two questions actually. For Pascal pan-retinal photocoagulation, do you recommend the pattern like 5 into 5, 3 into 3 like that? Because I have seen my seniors doing 5 into 5 like, and the laser marks are not so expanding. As you already told, it is less expanding. So I felt it like 3 into 3 or a lesser pattern will have a better impact. And the scar, for usually we keep one burn spacing. That is for the burns to expand. So if we keep a Pascal like pattern, do you recommend less spacing
Not
or effectiveness?
Not necessarily, because your burns will be still in that pattern, even if it's a bigger pattern, that means still your burns will be correctly placed. Only thing is, it's faster, less patient pain will be there. There is a lesser, most likely you'll require more additional PRP will also be
Yeah, I have seen
required.
patients coming for more ad PRP after a Pascal than a lesser.
Yeah, I
pattern.
still prefer single spot. It may be
Single spot. Thank you, sir.
Thank you. I'll like Dr. Rahul to come for his next talk.
So good morning, everyone. At the outset, I would like to thank Rohan for including me in this instruction course. So I'll be talking about follow-up and addressing complications from laser treatment. So let us see a case of central serous retinopathy. Now, if you see this patient, he had macular fluid in the color fundus picture that you can see. You can see a typical dome-shaped subretinal fluid in the OCT. The FFA showed a leak just nasal to the fovea. Now, this patient underwent a focal laser. The subretinal fluid resolved, and the patient was all fine. 2 months down the line, the patient came with a recurrence of subretinal fluid. Now, we might actually think it might be a recurrence of CSR, but on clinical examination, the patient had a scar just nasal to the fovea where the laser was done. And when an FFA was done, it was features of CNVM. The patient underwent intraretinal anti-VEGF, and the fluid fluid resolved, and the patient was all well. Now, what this happened? When we do a focal laser, we have to remember that we are not trying to burn the RP there. We are just our purpose of doing the laser is just to stimulate that RP. So ideally, when we do a laser for CSR, try starting with the test burns outside the arcade, come to the faintest burn, and then probably even you might reduce it a little bit and then hit the leak. So you should not burn that area. So if you have a choroidal neovascularization, get an FFA ICG or OCT angiography, and the treatment for that will be anti-VEGF injections. So also along with that, sometimes what can happen is there is a macular fluid, right? And most of the time the leak would be just beneath the in the fluid. So when we hit the, there's a tendency when we hit the leak, you don't see any burns. And what happens is the natural tendency is to increase the keeping on increasing the power. And when we keep on increasing the power, the next thing what happens is there will be the laser scar would be, it will be much more disastrous, powerful burn. And then you end up having atrophy, that is all creeping burns. And what happens is over a period of time, if you see, when you do a fresh laser, it appears white. And over a period of time, the pigmentations happen later. And that is when this laser scar actually enlarges and it can actually cause a scotoma since it is very close to the fovea. So how do you avoid that? One, like I said, use the lowest power. At least try to do laser, focal laser only when it is more than 500 microns away from the fovea. If it is subfoveal, yes, the best treatment I would recommend is photodynamic therapy, but sadly we don't have that anymore. So subthreshold laser treatment is a better option. Now, when we talk about pan-retinal photocoagulation, this I feel is the most important complication that we all tend to ignore. The patient, this is one of the most common reason why the patients tend to drop out. And we see a lot of patients, they would have undergone one sitting of PRP or 2 sittings of PRP, lost to follow-up, and then they come to us with a vitreous hemorrhage or a TRD. This because we do not address this complication as much, because we just take it like, laser is there, some amount of pain will be there. Do not disregard that. It is one of the most important things that we should all look into. So if the patient has pain, give them cold compresses. You can give them oral non-steroidal anti-inflammatory drugs. And when you do the laser, do it with a reduced power. You don't need to burn that end thing. It's not like that retina is, yes, it is hypoxic. You want to turn it to anoxic, but you don't want to create a hole there, right? And the another thing I would recommend is doing multiple sittings. See, we all talk about PRP in 2 to 3 sittings, but no, all 5 fingers are not alike. If you see a patient, the pain threshold for every person in this room is different. So when you do a laser for such patients, there might be some patients who might not tolerate the discomfort or pain that much. There's no hard and fast rule that you have to finish off the PRP in 2 sittings. If the patient wants, give them 4 sittings or 5 sittings. The purpose is to do a good laser, not the number of lasers. So even if the patient tolerates 200 burns, yes, fine, go ahead with 200 burns and take it to multiple sittings, but make sure that the patient completes the PRP. The another thing is, sometimes what happens is choroidal detachment. Now, if you see the image on the left, you will see a large proliferation in the disc, around the disc and around the arcade. This patient started underwent PRP, and after the PRP, the patient had a huge choroidal detachment nasal to the in the nasal periphery, and this is in the right eye. You can see a small choroidal detachment there. Now, when you see a patient with choroidal detachment, how do you go further? Withhold further laser. The patient might be coming from 100 kilometers, 200 kilometers. Just because of the patient comfort, do not add laser because inflammation is always there. Whenever you see choroidal detachment, there are two causes. One is hypotony, another thing is inflammation. By doing a laser, you're only going to further worsen it. So to withhold further laser, start the patient on a hourly topical steroids, start the patient on cycloplegics. A short course of oral steroid actually helps. If the blood sugars are under decent control, you can probably give a short course of oral steroids for probably 5 days or 1 week, and it usually comes down in a week's time. Also, at the same time, try to look for systemic hypertension. This is one thing which I have seen in my practice. I have very few patients who have developed choroidal detachment even post-surgical. We do small PRP here and there after the surgery, during the surgery in a TRD case. And when I look at these patients, usually will tend to have a systemic hypertension, and most commonly they will have a renal parameters will be deranged. They might have been a diabetic I just had a patient 1.5 months back, type 1 diabetic, 45-year-old guy, did the surgery, he was on OHA, had asked renal issues, no renal issues, creatinine was 1.2, but when I checked his urine sugars, his microalbumin was around 1400. His urine protein was 4 plus. So nephropathy has already started kicking in. And you know what happens is sometimes the physicians don't address the nephro problem. They just look at the blood sugars and they keep on treating that. So when you see choroidal detachment, make it a point that you look at the hypertension systemic parameters and also the renal parameters. Now, when you do the laser, when you see a proliferative diabetic retinopathy and you see proliferations, we want to add the laser, yes, but try to steer off away from the proliferation. Now, this is one of my patients. My junior had done the laser. If you see here closely in the superior part, it is a freshly, this is 1 week post laser. You can see the superior burns. I don't have a wide angle picture, but you would have clearly seen the lasers come from above, and you can see the nasal polyps here, and all the polyps came here, very close to the proliferation, and right in the center, in the polyp, a laser burn hit, and you can see it just opening up. This patient, post 1 sitting of PRP, 2 weeks down the line, patient developed a combined retinal detachment and had to be operated. So whenever you see proliferation, stay away from the polyps, at least 2 to 3 disc diameters away. And grid lasers and focal lasers, yes, like I said, when we do a laser, remember, especially in the macular region, the RP is the thinnest at the fovea. And as it goes you go to the periphery, the RP becomes thicker. So when we do the laser in the macular region, the power should always be less. So what happens is that is the reason in grid lasers, which we rarely do nowadays, we prefer to do more of focal laser or anti-VEGF. But when you do a laser, try to keep the power burn less, because if you do a larger power, you end up creating a breach in the RP Brooks membrane and you're inviting trouble with the CNVM. So if you have a CNVM, you have to treat it with anti-VEGF injections. Sometimes because of heavy burns, you might also develop subretinal fibrosis. And because it is a macular region, such a sensitive area, these patients are definitely going to have some vision field loss or scotomas. Now, barrage laser. You see a break, HST or something like, or a lattice degeneration with hole, you tend to burn them when with the lasers. And when you do the laser, you don't need to have chalky white burns. That is not the sure factor that it will not, the patient will not develop an RD. Yes, if you see them, just a decent enough burns should be enough. Complete the entire region. Make sure that it is either you complete encircle the complete lesion or you connect it to the aura. So what happens is when you do a laser, there is some amount of inflammation that is happening. Most of these patients tend to have a PVD. So what happens is all these inflammatory cells come and settle over the macula. And what happens is next is a epiretinal membrane. When you have an ERM, you can actually, if the patient's vision is fine and the patient is not symptomatic, you can observe. If the patient is symptomatic, metamorphopsia, you have to go, the patient has to undergo a surgical removal. Now, another thing is anomalous PVD. Now, like I think Dr. Shishir already mentioned, many times when a patient comes to you with the, you examine the patient, you see lattices. Now comes the question next, what do you do next? If the patient is, there are certain indications when you do the laser. One, if the patient is undergoing any eye surgery, suppose a patient with lattice is undergoing a cataract surgery. Now, if you remember, we see the patients of post cataract surgery day 1 week or 1 month. Now, do you know why is the follow up like that? Because after 1 month or even after PRP or everything, 1.5 months, that is the time. What happens is some amount of even though you don't have a PCR, some amount of hyalur disturbance is happening, and because of the inflammation, the PVD is going to get evolved, right? So when you see a cataract surgery patient with or any LASIK patient with peripheral retinal conditions, you have to treat it. Like LASIK, if when you do the LASIK, Shishi just told, when we keep the suction, there is a theoretical chance that the PVD might get evolved. Especially if you look at PRKs and all, we don't do any suction. So that, if you ask me, there's no need for peripheral lasers, but are prophylactic lasers in such condition. But then, medical legal aspect. If you all know, we all say the LASIK patients are the most story patients. Because the reason, because you have a 6'6" patient and you want to hit them give them 6'5", 6'4", right? So such patients is always better to be safe than sorry. You see a peripheral lesion, you do a barrage and keep it. So if you have a patient with undergoing, if you're undergoing a say search, so then only do a laser when it's indicated. Otherwise, keep a close watch. Thank you.
Thank you. Does anybody have any questions? Thank you. We'll move on to the